Operations in Oxygenation, Pathophysiology and Management. The respiratory system provides oxygen for cellular metabolism, and it also removes carbon dioxide from the body. In the upper airway, we have the nose, sinuses, turbinates, pharynx, and larynx. The nose itself is divided into two areas that are separated by the septum. The mucosal lining warms and humidifies inspired air, while the mucus traps small particles to help prevent lower respiratory complications. An important structure in the larynx is the epiglottis. This covers the opening to the larynx when swallowing and helps us prevent aspiration. Our paranasal sinuses include the frontal, ethmoidal, sphenoidal, and maxillary sinuses, and the mucosal lining from the nasal cavities continues its work here. The lower airway consists of the trachea, bronchi, bronchioles, lungs, and alveoli. The alveoli is where the exchange of oxygen and carbon dioxide take place. Accessory structures will include the diaphragm, which separates the thoracic and the abdominal cavities, and the mediastinum, which is a wall that divides the thoracic cavity into two halves, and that is lined with pleura. Pleura is a sac-like serous membrane. Visceral pleura is what covers the lung surfaces, while the parietal pleura covers the chest wall. There's also a serous fluid that will lubricate the visceral and parietal pleura. Main functions of the respiratory system are respirations, where oxygen and carbon dioxide are exchanged between the atmospheric air and the blood, and between the blood and the cells. And ventilation, which is the actual movement of air in and out of the respiratory tract. Mechanisms of respiration include inspiration, which is the movement of oxygen into the lungs, expiration, which is the removal of carbon dioxide from the lungs, diffusion, which is transferring a substance from an area of higher concentration to an area of lower concentration, perfusion, which is the flow of blood into the pulmonary circulation, and distribution, which is the delivery of atmospheric air to the separate gas exchange units in the lungs, which are going to be the alveoli. Alveolar respiration will determine the amount of carbon dioxide in the body, and this aids in the acid-base balance. Increased carbon dioxide, primarily in the body fluids, is carbonic acid. This causes the pH to decrease below normal, which would be 7.4. A decreased carbon dioxide will cause the pH to increase above 7.4. Kidneys excrete excess hydrogen ions, and this will help keep the serum bicarbonate levels near a normal level. Lungs will then eliminate carbonic acid by blowing off more CO2, and they conserve CO2 by slowing down the respiratory volume. Oxygen transport occurs through dissolving in the plasma or combining with hemoglobin in the red blood cells, and that's called oxyhemoglobin. Oxygen diffuses across the cellular membranes. Carbon dioxide diffuses from the tissue cells to the blood. Imbalances are going to be discussed more thoroughly the next 8 weeks in our acid-base imbalances. But we have respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Perfusion, once again, is the blood supply to the lungs, and this is how the lungs will receive nutrients and oxygen. The bronchial arteries will supply blood to the trachea and the bronchi, while the pulmonary artery transports venous blood from the right ventricle of the heart to the lungs. Blood will then circulate through the pulmonary capillary bed, where the diffusion of oxygen and carbon dioxide will occur. Cardiopulmonary status is going to be determined by the ventilation perfusion ratio, or VQ ratio, and it indicates the effectiveness of airflow within the alveoli, which is ventilation, and the adequacy of gas exchange within the pulmonary capillaries, which is perfusion. So, movement of air into and out of the lungs sufficient to maintain normal arterial oxygen and carbon dioxide tensions is termed what? This is ventilation, which is the actual movement of air in and out of the respiratory tract. And this process requires a patent airway. In other words, we have to have an airway that's open and an intact and functioning respiratory muscle. Respiratory insufficiency will develop if there's too much interference with ventilation, diffusion, or perfusion. Abnormalities will include hypoxia, which is decreased oxygen in inspired air, hypoxemia, which is decreased oxygen in the blood, hypercapnia, which is increased carbon dioxide in the blood, and hypocapnia, which is the decreased carbon dioxide in the blood. Primary factors include airway resistance, which is related to the airway diameter, the rate of the airflow, and the speed of the gas flow. In other words, do we have any constriction of the airways? Are we breathing in air too fast, too slow? Examples would include asthma, chronic bronchitis, and emphysema. And the other primary factor would be lung compliance. We have a decreased surfactant, which helps prevent the collapse of alveoli, fibrosis, edema, or atelectasis, which affect lung compliance. And atelectasis is the collapse of the alveoli. So different things happen as we begin to age. We see the cartilage in the nasal septum actually increasing in length, and it can harden, and this can create airflow changes. The alveoli walls will become thinner and contain fewer capillaries, so we have a decreased gas exchange. The lungs begin to lose elasticity. We see a diminished lung expansion. Muscle tone, cough reflex, and the amount of cilia will decrease. And the older client is at an increased risk for respiratory disease. So during our assessment, we need to get our history. We look at the general health. Do they have a family history of respiratory disease? What is the frequency of any respiratory illnesses, allergies, or do they have a smoking history? Are they on any type of respiratory treatments or medications? Have they had any pulmonary tests? And what's their occupation? Do they have a problem with tolerating exercise? Do they have pain with breathing? And what's their level of fatigue? With the physical examination, look at their skin color, level of consciousness, mental status, respiratory rate, depth and effort, and the rhythm. Are they using accessory muscles to breathe? In other words, are they using some of their stomach muscles or their chest muscles to aid in the breathing effort? What is the shape of their chest and the symmetry of the chest movement? Does one side rise with breathing and one side does not? Do they have any clubbing of the fingers? Look at the nose for signs of flaring, injury, or inflammation. Is their trachea in line, or has it been pushed off to one side or the other? Do they have dyspnea with or without exertion? Do they have pain on inspiration? An increased or more frequent cough? Increased sputum production or a change in the color or consistency of the mucus? Do they have any wheezing or hemoptysis? How about the breath sounds? Percussion and palpation is usually done by a more experienced nurse for normal findings and abnormalities. So if you have the experience, go ahead and do so. But we can all auscultate breath sounds. Remember that normal breath sounds will include the vesicular sounds, which are produced by air movement in the bronchioles and the alveoli, and bronchial sounds, which are produced by air movement through the trachea. And then we have the bronchovascular sounds, which are the normal sounds that are heard between the trachea and the upper lungs. So are you hearing any adventitious lung sounds, which are going to be abnormal lung sounds? And this will include crackles, and some people will still call them rails, which resemble static, or the sound that's made by rubbing the hair strands together by your ear. Sometimes those crackles will clear with coughing. So if you're hearing those crackles, if the client is able, ask them to cough and see if those crackles do go away. If they don't go away, this can indicate there's some fluid in the alveoli. Another adventitious lung sound is wheezes. These are hissing or whistling sounds. Excuse me, or they can be more of a sonorous sound, which is a full and deep sound, kind of like a crackle, but just deeper. And these are heard during inspiration and expiration. We consider it to be more of a musical sound. This will indicate a narrowed or partially obstructed airway. The sonorous wheezes were formerly called bronchi, and they're lower pitched. They're heard in the trachea and the bronchi. Once again, this can indicate there is some blockage there, some fluids of some kind, and that is preventing a normal breathing sound. Friction rubs will be heard as crackling or grating on inspiration and expiration, and these will occur in the client with pleural inflammation. And the last one is stridor. Stridor is going to be a sound that we hear when we have a significant airway obstruction and very little to no air is getting past this obstruction. And it sounds kind of like this. So while conducting the physical examination during assessment of the respiratory system, which of the following would describe lung sounds that are produced by air movement through the trachea and are loud with a long expiration? These are going to be your bronchial sounds, which are auscultated over the trachea and again are loud with long expiration. There's several different diagnostic tests that can be done to help determine the adequacy of the respiratory system. This will include the arterial blood gases, or ABGs. This determines the blood's pH, the oxygen carrying capacity, levels of oxygen in the blood, levels of carbon dioxide in the blood, and levels of bicarbonate in the blood. Pulmonary function studies are going to measure the functional ability of the lungs, and these can be accomplished with something as simple as a spirometer. Sputum studies will reveal pathogenic microorganisms and cancer cells. Culture and sensitivity tests will help determine appropriate antibiotics. A pulse oximetry is going to determine the oxygen content of the hemoglobin, and it measures oxygen saturation of arterial blood. Radiography or X-rays is going to determine the size, shape, and position of the lungs and other structures of the thorax. A pulmonary angiography will use radioisotopes to view the arterial circulation of the lungs. And lung scans, such as a ventilation perfusion scan, abbreviated as a VQ scan, the gallium scan, positron emission tomography or PET scan, will all be used to help diagnose lung cancers, COPD, and pulmonary edema. A bronchoscopy will allow visualization of the larynx, trachea, and bronchi, and they can help diagnose, treat, or evaluate lung concerns or obtain some biopsies. A laryngoscopy, mediastinoscopy, and thoracoscopy will all allow for visualizations of other structures. Thoracentesis is the removal of excessive air or fluid accumulation that happens between the visceral and parietal pleura. And it has to be aspirated by inserting a needle into the chest wall. This is a procedure that can be done at the bedside with the client leaning over a bedside table at the edge of the bed. While the bronchoscopy, they usually go to surgery and receive some type of anesthesia for the actual procedure. So how do we manage these clients? We need to make sure that we're providing appropriate education regarding disease processes, testing, treatments, medications, etc. We also need to provide adequate rest periods for these clients. Repeat any questions as necessary. Sometimes providing small, frequent meals to these clients is very beneficial. And following procedures, assessing for respiratory distress, chest pain, and any bleeding. So the physician orders arterial blood gases to determine various factors related to blood oxygenation on a client that presents in respiratory distress. What site can ABGs be obtained from? This is usually done from the radial artery. The ABGs will determine the blood's pH, oxygen carrying capacity, and the levels of their oxygen, carbon dioxide, and bicarb. These blood gas samples are obtained through an arterial puncture, usually once again at the radial because it's the most easily accessible. It can also be done at the brachial or the femoral artery in other situations. So with our nursing priorities, we know that we can have the decreased cardiac output, airway obstruction, inadequate oxygenation, the potential for infection, and ineffective peripheral circulation. But there's also the potential for a fluid volume deficit, anxiety. When people can't breathe, they become very anxious. We may also have pain or inadequate nutrition. It takes a lot of effort to breathe, and if you're struggling to breathe anyway, it takes even more effort to eat. So a lot of these people may be anorexic. We may also see an impaired communication or limited activity tolerance. So complications from respiratory issues can include impaired breathing, infection, pulmonary hypertension, respiratory failure, or respiratory arrest, in addition to heart failure or cardiac arrest if the respiratory issue of respiratory failure or arrest is not addressed. With our client education, we have to teach them appropriate hand and respiratory hygiene to help prevent transmission of any infectious particles. So we teach them the hand hygiene. We teach them to catch their cough or their sneeze, preferably in a tissue, but otherwise in their elbow, but not with their hand. Elevate the head of the bed might help with breathing. Humidifying the air will assist in keeping secretions moist and also helps prevent epistaxis. Clients must follow the medication regimen, complete all their antibiotics, take preventative or maintenance medications as they are prescribed. Encourage the client to quit smoking and encourage them to avoid respiratory irritants. And sometimes respiratory irritants are found in occupational hazards. They work in lawn care and they're constantly blowing up dirt that they're inhaling. They work in an elevator where there are constant grain dust. They work in an area where there's a lot of chemicals, etc. We also teach pursed lip breathing technique, and this will be especially helpful with the COPD clients. And we encourage vaccinations, especially the pneumonia and the influenza.